Cancer-related cases are rising significantly, with increasing complexity in diagnosis and treatment. Content, community and innovation. IAIO serves thousands of cancer professionals globally through our diverse divisions, products and services. Our meetings and events with world-class speakers educates over 2,000 cancer professionals annually to foster collaboration and knowledge sharing. In 2025, IAIO will bring over 500 plus hours of expertly designed scientific meetings and events to enhance professional practice of cancer professionals. IAIO brings you your virtual meeting secretariat, the exclusive suite to manage your meetings and events. We execute your concept, and together we bring the best of IAIO. Oncology Updates, our flagship series, delivers the latest insights on all categories of cancer, bridging the cancer research and industries. We bring you the latest innovation, therapeutics, clinical trials, and ongoing studies. Our annual Congress, Indo-Oncology Summit, unites world-class speakers and delegates, offering a premier platform for young oncologists to showcase their research, learn, and network. Encouraging cross-disciplinary cancer research is the need of our, so we bring you International Congress on New Frontiers in Uro-Oncology and Uropathology, one of the largest scientific program in India. IAIO's knowledge partnership with industries brings you sponsored CMEs to educate healthcare professionals on the latest therapeutics, ongoing trials, and clinical studies. Join as knowledge partner with IAIO to elevate, lead and innovate. IAIO's Academy is the exclusive learning management system for you, where module and courses are designed for young oncologists looking at the need of next-generation cancer sciences, so that we build the capacity of oncologists for next decades. The IAIO Academic Council comprises a diverse group of subject matter experts from various oncology disciplines to deliver education through online classes in affordable prices with opportunities of academic grants. At IAIO, we believe every step of your clinical practice could lead to a new innovation in cancer care. We partner with clinicians in every step, for enhancing their practice information and patient data to novel research by transferring your treatment's methodologies into scholarly publication. Our global network brings researchers of similar interest for collaborative research and drive ongoing studies and decentralized clinical trials. IAIO Library and Resources offers a vast collection of scholarly materials to keep you updated with latest insights on best practice methodologies. We understand upscaling your knowledge is the need of humanity. Let's give a healing touch to the life of cancer patients and survivors through initiatives of IAIO Humanity. Our patient and public welfare initiatives are driven by IAIO Community. Our communities and networks bring together experts from across the globe, fostering an environment of collaboration, shared knowledge, and ensures comprehensive support across all branches of cancer care. Join IAIO's exclusive membership with Abode of Opportunities, where we believe in a world where knowledge drives progress in oncology. Let's shape the future of cancer care together. Cancer-related cases are rising significantly, with increasing complexity in diagnosis and treatment. As oncology science evolves with new discoveries and therapeutic models, the fight against cancer demands an integrated approach among organizations and healthcare professionals. IAIO, the world's fastest-growing integrated oncology network, stands to fight cancer through three core verticals: content, community, and innovation. IAIO serves thousands of cancer professionals globally through our diverse divisions, products and services. Our meetings and events with world-class speakers educates over 2,000 cancer professionals annually to foster collaboration and knowledge sharing. In 2025, IAIO will bring over 500 plus hours of expertly designed scientific meetings and events to enhance professional practice of cancer professionals. IAIO brings you your virtual meeting secretariat, the exclusive suite to manage your meetings and events. We execute your concept, and together we bring the best of IAIO. Oncology Updates, our flagship series, delivers the latest insights on all categories of cancer, bridging the cancer research and industries. We bring you the latest innovation, therapeutics, clinical trials, and ongoing studies. Our annual Congress, Indo-Oncology Summit, unites world-class speakers and delegates, offering a premier platform for young oncologists to showcase their research, learn, and network. Encouraging cross-disciplinary cancer research is the need of our, so we bring you International Congress on New Frontiers in Uro-Oncology and Uropathology, one of the largest scientific program in India. IAIO's knowledge partnership with industries brings you sponsored CMEs to educate healthcare professionals on the latest therapeutics, ongoing trials, and clinical studies. Join as knowledge partner with IAIO to elevate, lead, and innovate. IAIO's Academy is the exclusive learning management system for you, where module and courses are designed for young oncologists looking at the need of next-generation cancer sciences, so that we build the capacity of oncologists for next decades. The IAIO Academic Council comprises a diverse group of subject matter experts from various oncology disciplines to deliver education through online classes in affordable prices with opportunities of academic grants. At IAIO, we believe every step of your clinical practice could lead to a new innovation in cancer care. We partner with clinicians in every step, for enhancing their practice information and patient data to novel research by transferring your treatment's methodologies into scholarly publication. Our global network brings researchers of similar interest for collaborative research and drive ongoing studies and decentralized clinical trials. IAIO Library and Resources offers a vast collection of scholarly materials to keep you updated with latest insights on best practice methodologies. We understand upscaling your knowledge is the need of humanity. Let's give a healing touch to the life of cancer patients and survivors through initiatives of IAIO Humanity. Our patient and public welfare initiatives are driven by IAIO Community. Our communities and networks bring together experts
So can we start the session?
Yes, you can start.
Yes, sir. Thank you so much. Good evening, one and all. I welcome our program director, speakers, panelists, and all the participants to this session on expert insights on lung cancer. I would like to request Dr. M. V. Chandrakant sir, medical oncologist, Narayana Health Kolkata, our program director of this event, to give the introduction and set the context. Over to you, sir.
Thank you. Good evening, all of you. Thank you all for joining on time of your busy schedule. Today, we have a series of talks on the recent advances in lung cancer space, followed by a panel discussion. So, hope this will be helpful for all of us and changing our practice. So without wasting much time, I would request my dear colleague and friend, Dr. Chakor Ora, to start the first session on transforming tomorrow breaking barriers in the management of extensive stage small cell lung cancer. Over to you, Dr. Chakor.
Thank you, Chandrakant sir, for and the organizers for giving me this opportunity. And I like to share my slides. Can I do that? Or will the presentation be run by you?
No, sir, you can share the slides.
Okay. Wait a minute. Let me just. Can you please do that? I mean, I'm finding it a little difficult with the.
Sure, sir.
Yeah, please do it. So I'll just run through the presentation as you. So I'll not waste more time. I'll quickly just start off, and she will share the slides. We all know that the small cell lung cancer variant, or the type of, or this type of lung cancer, is an aggressive variant. At the incidence itself, at the diagnosis itself, almost 2/3 of the small cell lung cancer patients have metastasis or have an extensive stage. And the prognosis of this particular disease has been dismal for since ages, or since all this while it has been dismal. The overall survivals have been in the range of 1 year or 1.5 years, not hardly one more than 1 year. Next slide, please. Next slide. So we know that most of the patients will have brain metastasis at the diagnosis. Not most, but many of the patients will have brain metastasis at the diagnosis. And the standard of care, next slide. The extensive stage versus limited stage. So today we'll be discussing the role of immunotherapy in addition to chemotherapy in the extensive stage patients. Extensive stage is any disease which is out of a single field of radiation. So a disease limited to the to only one side of the thorax is considered to be limited stage. Anything more than that will be extensive stage. Next slide, please. So most of the patients do relapse within 6 months of duration, and that's why in spite of responding initially, most of the patients will have a disease relapse within 6 months, and that's the reason why we are more worried with this particular diagnosis, with this particular disease, and a lot of advances need to be done. Next slide. So this is a slide which shows that in spite of wonderful advances in multiple other cancers, over the last 4 decades, since 1980s, till 2012 or 2020, the 1 year survival of small cell lung cancer patient has been only 33%, and 3 year survivals have been in the tune of 7 to 9%. Next slide. So this is another wonderful slide showing an entire timeline from 1985 to 2021, which shows that we got the regimen of cisplatin etoposide in 1985. Carboplatin etoposide came in 1999, topotecan somewhere in between at 1996. And till 2018 or till 2019, we did not have any further advances in the management of extensive disease small cell lung cancer. Since 2019, 2020, we had additions of atezolizumab, durvalumab, pembrolizumab, and nivolumab to the chemo regimens or as an individual drug. Nivolumab, pembrolizumab have been withdrawn. So what remains in the race is durvalumab plus etoposisplatin or etopocarbo, or pembrolizumab or atezolizumab plus etopocarbo. Next slide. So immunotherapy, as I've mentioned, yes, immunotherapy, there are 2 studies which have shown the benefit. Next slide. So the 2 studies are Caspian and IMpower 133. Caspian is your own study of AstraZeneca, where durvalumab was added to etoposide plus carboplatin or cisplatin, and that has been recommended as the first-line regimen by all the renowned guidelines. And similarly, atezolizumab plus carbo plus etoposide has also got recommendation or has been approved in the first line now. Next slide, please. We'll look at the differences between these 2 trials in the later half or the last part of the presentation. Next slide. So this rationale of adding immune checkpoint inhibitors to chemotherapy is known to all of us, that chemotherapy will cause lysis of the cells or tumor destruction that will release the antigens, which will be picked up by the immune cells, and immunotherapy will improve or restore the tumor-specific T-cell immunity. And that's how we expect a combination of checkpoint inhibitors with chemotherapy to give us synergistic results beyond addition. So not only additive results, but something synergistic. Next slide, please. So this is the Caspian study design, where patients were randomly assigned, around 800 patients were randomly assigned to either receive durvalumab plus EP or EP alone. And third arm was durva treme plus EP. And the primary endpoint of this study was overall survival. Secondary endpoints were PFS, OS at 18 months, overall response rates, patient-reported quality of life, and then safety and tolerability. They had also put some exploratory endpoints. So around 240-250 patients were randomized to each of the 3 arms. And patients and the physician was given the choice whether you add cisplatin or carboplatin. Both were allowed in this particular trial. Also, patients who had brain metastasis with or without treatment were included in this trial. Next slide. So this Caspian next slide. So this study is actually can be considered like a real world study. The only limitation being performance status 0 and 1 were only included. PS2 or 3 patients were not included. When we treat small cell carcinoma patients, we actually try to figure out whether the poor performance status is because of the disease itself. If it is disease induced or disease related poor PS, it may reverse quickly with the start of chemotherapy. And so such patients can be considered as eligible for the treatment as compared to those who have poor PS irrespective of the disease. So coming straight to the results, the durva plus EP arm showed significant improvement in the overall survival at 1 year, at 2 years, and at 3 years. There was around 13 to 14% improvement at 1 year, and which has stayed along till the 3-year time point. So there is a 3-year OS of 17.6% as compared to just 6% in the EP arm. And this was statistically significant. The hazard ratio was 0.71. So although numerically, if you look at it, the median OS just improved from 10 months to 12.9 months. Next slide. Next. Please click once or twice more. Next. Again, next one. Move on to the next slide, please. Yeah, so the forest plot shows that the OS benefit was observed across all relevant subgroups. Let it be the gender, let it be platinum agent, whether we have used carboplatin or cisplatin, whether the patients were had a PS of 0 or 1, so most of the significant subgroups has showed an improved survival. Smokers also showed, as we expect smokers to have a benefit with immune checkpoint inhibitors, smokers had a benefit. Non-smokers, the subgroup was only 37 patients. Crossing unity really doesn't make a difference over here. Similarly, if you see Asians were only 78 in number as compared to the 458 in the non-Asians. So wherever you see the line is crossing unity, it is a very small subgroup of patients, so I'll not give it that much significance. So I'll rather consider this as a standard of care if the patient is affording. Next slide, please. The PFS, again, around 8 to 9% benefit of PFS at from 12 months, 18 months, and at 24 months. So a significant improvement by around 8 to 10% chances of improvement. Next slide, please. The overall response rates were slightly better, again 10%. So this study is basically of those 10% patients who have got the benefit. The median duration of response was same in both the subgroups, but it is after that the patients who really benefited have shown improved PFS and OS. Next slide. So next slide. So this is something which may be helpful, as we all know, as all medical oncologists know, that PD-L1 or TMB or MSI may not be the appropriate markers in selecting whether the patient will benefit with immune checkpoint inhibitors here in small cell lung cancer. So there are two methods, the Rudin et al. Method and Gay et al. Method, which were used for the analysis. Again, a subgroup analysis was done, and it showed that the inflamed subtype or the YAP1 subtype showed the longest benefit or longest OS in the Durva EP arm. And so this may be a biomarker that we are looking forward to. Whether it will be practical, feasible or not, that can be discussed later. But this is the particular subgroup of patients with extensive disease, extensive stage small cell lung cancer patients who actually benefited or have shown the best results. Well, there is another group which is POU2F3, the POU2F3 group, which actually did not show or perform the worst. Next slide. So patient-reported outcomes also have shown that yes, most of the patients had a better quality of life and longer duration of life with a better maintained health, a better quality. Next slide. This is the other arm which had addition of tremelimumab to the D and EP, and that has shown results similar to the Durva plus EP arm, where you see around 15 to 16% of patients surviving at 3 years. So if you compare with the EP, it is done better. If you compare with single agent Durva, then probably it's one and the same. Next slide. Toxicities, no new safety signals were identified. Patients tolerated the regimen just as they do EP. So hardly any additional new toxicities identified here. Next slide. Next, please. So management of brain metastasis. Next slide. So molecular subtype, Mr. Amir Riaz Sheikh is asking which molecular subtype. So that was the inflamed subtype as per that classification. So next slide, we have already seen this slide up before. So brain metastasis, almost 10% of patients had some brain metastasis already. And so OS with brain mets and without brain mets, it's actually a very small number to say that this is significant, this is not significant. It's a game of numbers. I'll skip this part. Move ahead, please. Next slide. Next slide. So serious adverse events were not really much more in numbers as compared to that in the EP arm. Next slide. So this is a comparison between the IMpower 133 and Caspian, and it clearly shows that, okay, Caspian is really a real world study where patients were allowed, whether they had received cisplatin or carboplatin, patients were allowed to take in the control arm, all 6 cycles of chemo were allowed, while in the IMpower 133, the treatment in the control arm had to be stopped at 4 cycles. PCI allowed in the experimental arm. So in the Caspian, PCI wasn't given. Those patients were excluded. PCI allowed in control arm were included in both the patients. Untreated brain mets were included in the Caspian, which is again a real world scenario. So if you compare the two immune checkpoint inhibitor trials, IMpower 133 of atezolizumab versus Caspian where durvalumab was used, the Caspian is more of a real world study as compared to IMpower 133. And so if you have to really go by the books or go by the guidelines, then durvalumab becomes more useful or more applicable in our daily practice. Next slide, please. Next slide. So if you look at the median OS, 12.3 months in IMpower 133 and Caspian is showing a median OS was 12.9. If you actually overlap both the graphs, it will be almost one and the same. Next slide, please. So PCI, there is a lot of conflict or a lot of debate which goes on about PCI, and that's what have been that's what has been mentioned over here. Has to be highlighted rather. Okay, PCI does definitely show a reduction in the occurrence of brain metastasis, and multiple studies have shown that. But whether it really improves the overall survival, that nobody knows. There are 2 large studies, and both the studies have shown conflicting results. One shows there's no OS benefit of doing PCI. The other one says yes, there is a benefit of PCI. So there has been a conflict over there, and so that's in the chemotherapy alone era. If you come to the chemoimmuno era, we really do not know whether PCI will benefit these patients and how much benefit it will be. The neurotoxicity of PCI, we all know the long term, if a patient is to survive for a longer duration, then PCI today can lead to long-term neurotoxicities in the next 6 months or 1 or 1.5 years. So it is about those 17 or 18% patients who are actually living for 3 years or more now with the help of immune checkpoint inhibitors that the PCI may actually turn out to be more harmful than beneficial. So the debate may continue on this part. Next slide, please. Brain MRI surveillance, definitely yes, whether you do PCI or you do not. Brain MRI should be done at 3 to 4 month interval in the first year on follow-up, and then 6 monthly after that. Next slide. So to summarize, yes, we saw that extensive stage SCLC is aggressive. Immunotherapy plus chemotherapy and followed by immunotherapy maintenance is now a first-line regimen. It's approved, and Durva plus carbo or cis plus and etoposide, or atezolizumab plus carbo etopo is the preferred first-line treatment. And brain metastases are common, as we already know, and that poses a significant challenge for monitoring clinical practice. And monitoring in clinical practice must be done. So with that, I will end my talk over here. I hope I've not overshooted much, but I think still, yeah. So thank you. Thank you for your attention.
Thank you for your informative session, sir. Next, I would like to invite Dr. Shweta Subramanian, MO, Medical Oncologist at ESIC Hospital, Bangalore, to give a talk on evolving landscape of lung cancer.
Yeah, thank you. So without much delay, I'll just continue with my talk, Evolving Landscape of Lung Cancer Diagnosis and Therapy. So this is the overview of my presentation today. Early diagnosis of lung cancer, basics of lung cancer, Tagrisso, the indications, Imfinzi indications, and recent advances in lung cancer. So early diagnosis of lung cancer, we all know even today, like at least most of our patients, at least 2/3 of our patients present to us with advanced disease, and there is no screening which is very effective in lung cancer. So this is the global data which shows that lung is the major cause for cancer related mortality. And in India also, lung cancer stands as the fourth most common cancer causing death. So proportion of patients according to extent of disease, we all know, like I already told, 2/3 of our patients at least are in stage 4 disease, and we hardly see any stage 1 and stage 2 patients. Usually it accounts to around 10% of our patients, and most of the patients, even though treated with the curative intent, tend to recur within 3 years. So screening benefits. So detecting the disease in early stage, early diagnosis means more effective treatments and possibility of cure, increases the survival and improves the quality of life. Steps in lung cancer screening process. So we have to assess the risk. So and then go for screening in high risk patients, and then we can decide upon other diagnostic tests to confirm the suspicious nodules. So although screening exists in certain places in India, screening for lung cancer is not very effective because of multiple issues, like we all know, because so this is the NCCN guidelines. So NCCN lung cancer screening guidelines, they risk stratify based on certain criteria like smoking history, occupational exposure, cancer history, family history of lung cancer in cancer relatives, in first degree relatives. So disease history of COPD or pulmonary fibrosis, smoking exposure, that is secondhand smoke. So risk calculator to enhance determination of risk status. So in general, as a broad term, we can just remember that age 50 years and above and more than 20 pack years of history of cigarette smoking constitutes high risk. And these are the patients in which screening can be beneficial. So when we mention screening, it is usually indicates HRCT or CECT thorax rather than a chest X-ray. Chest X-ray is considered to be inferior in lung cancer screening. So low risk patients are those with age less than 50 years and less than 20 pack years of history of cigarette smoking. So here the screening is not recommended. So this is the stepwise approach in diagnosis. So initial presentation, it could be either detected by screening or an incidental finding, or a primary care physician can detect based on the symptoms. So or it could be an emergency presentation. So the routine clinical and history taking and physical examination will follow, and then followed by the laboratory and radiological investigations. So whenever there is a suspicious mass in the lung, so we usually look into, are there any suspicious lymph nodes? Are there any distant metastasis? So chest X-ray followed by chest CT or PET CT directly with an MRI. So are the usual imaging investigations. Pathologically, we always tend to get a tissue. So sometimes getting the tissue might also be difficult, but in metastatic cases, we go with a liquid biopsy also. So, but getting a tissue could be either CT guided biopsy in case of peripheral lesions, or like bronchoscopy or EBUS in case of centrally located tumors. So sometimes we need to go for a mediastinoscopy or thoracentesis, mediastinoscopy in case of doubtful nodal status also. So tissue testing nowadays never stops at histology and immunohistochemistry. It usually is followed by molecular testing. So given the availability of multiple targeted therapies. So basics of lung cancer. So we know about the histological subtypes, adenocarcinoma and squamous cell carcinoma. Basically, it is a non-small cell lung cancer and small cell lung cancer. So non-small cell lung cancer can be further divided into adenocarcinoma, squamous cell carcinoma, large cell carcinomas, and other histological subtypes of non-small cell lung cancers. So So small cell lung cancers usually constitute around 15% and non-small cell lung cancers constitute around 85% of the cases. If we look at the behavior of lung cancer patients, most of our lung cancer patients present with advanced stages, and most of the patients with advanced disease will have a brain metastasis also. So the incidence of brain metastasis is usually around 50%. So in small cell lung cancer, and this is associated with poor outcomes. This was already dealt with by the previous speaker, so I won't be going too much into small cell lung cancer. So lung cancer is no more considered a single entity. It's a heterogeneous disease. Now it's like usually the treatment part is dictated by the presence of mutations, particularly in advanced stages. So these are the few mutations which we usually get it done: EGFR, AL, CROSS, BRAF, NTRK, MET, RET, and also the PD-L1 testing. So to decide on treatment options, Tagrisso. So we know like oncogene-driven tumors or EGFR mutated tumors and others, they don't really behave like other tumors where there is no mutation. So these usually respond very well to targeted therapies, but if we don't start the targeted therapies, the chemo has a inferior role compared to targeted therapies. So this is the landscape how EGFR mutation has mutation detection and its treatment has evolved. So initially EGFR was identified, then Gefitinib came into got approved, then Erlotinib came into picture, then we got to know that there is some resistant mechanism and there is a T790 mutation, so which can be seen in post Gefitinib and Erlotinib patients or upfront also. So then they got approval for Osimertinib in 2015. So Osimertinib was particularly approved for T790M mutation post EGFR TKIs. So then they compared Osimertinib in first line and got approval for that against Gefitinib or Erlotinib. So, and we also have other things like Erlotinib and Ramucirumab as first line therapy. So FDA approval for Osimertinib as adjuvant therapy is also there, which was approved in the year 2020. We will be discussing about a few trials in the later slides. So this is the FLORA study design, which is the first-line therapy of Osimertinib in locally advanced or metastatic non-small cell lung cancer patients. So inclusion criteria was more than 18 years or WHO performance status of 0 or 1, exon 19 deletion or L858R. So with no prior systemic anti-cancer or EGFR TKI therapy, and stable CNS metastasis were also allowed. So Osimertinib with a dose of 80 mg per orally daily was compared with Gefitinib or Erlotinib, which was the standard of choice at that point of time. So crossover was also allowed in this study. So the endpoint was PFS. So there was a big difference in the PFS curves, and Osimertinib had a median PFS of around 18.9 months versus 10.2 months with a hazard ratio of 0.46 and p-value of less than 0.0001. So this gained approval for first-line Osimertinib compared to Gefitinib or Erlotinib. So overall survival final analysis also showed a benefit and favoring Osimertinib. So median OS with Osimertinib was 38.6 months compared to 31.8 months with comparator EGFR TKI. So 1 year overall survival was 89% versus 83%. 2 years overall survival was 74% versus 59%, and at 3 years also it was 54% versus 44%. There was at least a 10% of overall survival difference between the two arms in spite of crossover being allowed. So ADAURA, this is the adjuvant Osimertinib trial wherein completely resected stage 1B, 2 or 3A non-small cell lung cancer with or without adjuvant chemotherapy were included. So there should have been a confirmed primary non-squamous non-small cell lung cancer with an exon 19 deletion or L858R mutation present. So brain imaging was a prerequisite for this group of patients. So stratification was done based on stage, that is 1B, 2 or 3A, EGFR mutation, whether it was an exon 19 deletion or L858R mutation, Asian or non-Asian race. Osimertinib 80 mg once daily was compared with placebo once daily. So endpoints were primarily disease-free survival, So disease-free survival benefit with adjuvant osimertinib was established by this trial, and this is the trial which gained approval for adjuvant osimertinib in resected lung cancer patients. So median disease-free survival was 65.8 months compared to 21.9 months with placebo, and this was expected because we are not giving any trial. I mean, we are not giving any drug in the comparator arm, but we are targeting the EGFR mutation in the study arm. So hazard ratio was 0.23. It was quite significant. So updated disease-free survival in the overall population was 2-year disease-free survival was 90% with the osimertinib arm compared to 55% in the study arm, and 4-year disease-free survival was 73% compared to 38%. So there was double the benefit in terms of disease-free survival. So why is this important? Is like we know that by 3 years, most of the patients, at least half of the patients, usually recur. So even in curative intent, resected lung cancer patients. So, but look at the 3 years disease-free survival rates with osimertinib. So 85% versus 44%. There is a significant difference. So when it comes to use of osimertinib. So the hazard ratio was also very significant with a 0.27 hazard ratio. So overall survival, adjuvant osimertinib demonstrated a statistically and clinically significant improvement overall survival versus placebo in stage 1B to 3A disease. So there was a 10% overall survival difference at 5 years. So why osimertinib should be the drug of choice in EGFR mutated non-small cell lung cancer? Because it has shown better efficacy in brain mets as well as it delays CNS progression. So we all know that like brain metastasis is a very big issue when it comes to at least oncogene-driven lung cancers. They tend to spread to brain more easily compared to non-oncogene-driven tumors. So only 7 out of 10 patients get tested for second-line treatment options because most of our patients, they won't be fit for second-line therapies. So because of poor performance status, or in case of EGFR mutation positivity, there might be a secondary T790M mutation positivity, which is seen only in 40 to 50% of the second-line patients. So these patients might miss out osimertinib when we consider starting gefitinib or erlotinib as the first line and then wait for progression and then start osimertinib. So results show a significant improvement in disease-free survival with osimertinib compared to placebo in this adjuvant setting. So this has changed the treatment landscape in this population. So nowadays we consider giving adjuvant osimertinib in resected 1B, 2 or stage 3 patients, lung cancer patients. So osimertinib in the adjuvant setting aims to prevent disease recurrence and improve long-term outcomes, potentially offering a curative intent approach for these patients. So next comes Imfinzi indications, that is durvalumab. So how do we usually manage locally advanced stage 3 unresectable non-small cell lung cancer? Usually we discuss it out in a multidisciplinary team and we confirm or make sure that it is not resectable. Sometimes we go ahead with sequential chemoradiation, direct chemoradiation, and sometimes even nowadays we go ahead with neoadjuvant chemotherapy or neoadjuvant chemoimmunotherapy followed by resection if feasible. So, or neoadjuvant chemoimmunotherapy followed by definitive chemoradiation. So compared to definitive chemoradiation upfront versus sequential chemoradiation, always the former is preferred, although like many patients might be having a poor performance status. So at presentation, which might not allow them for upfront CTRT in Indian setting at least. So definitive CTRT is the standard of care for stage 3 unresectable non-small cell lung cancer. So concurrent chemoradiation is better than sequential chemoradiation, like I explained. So role of immuno-oncology in stage 3 lung cancer patients. So rationale for PD-L1 inhibitor following chemoradiation. We all know like how immunotherapy works. So it's basically an antibody response to an antigen release. So what happens when chemoradiation has been given to a patient? It has direct cytotoxic effects and induces immunomodulatory changes. So there will be increased antigen release from dying tumor cells. So that is known as an antigen storm. And there will be upregulation of PD-L1 and immunogenic cell surface proteins. So immunomodulatory changes in the tumor microenvironment. So all these things enhance the efficacy of immunotherapeutic drugs. So that is the rationale behind using immunotherapy after chemoradiation. So this is the PACIFIC trial which showed that durvalumab post chemoradiation in stage 3 lung cancer patients shows a benefit compared to placebo. So previously we never used to give any maintenance, or we just used to keep the patients on follow-up after definitive chemoradiation. So patients with stage 3 locally advanced unresectable non-small cell lung cancer patients So 18 years or older patients with WHO performance status score of 0 or 1 with an estimated life expectancy of more than or 12 weeks. So these were the population which were included in the PACIFIC study design. So durvalumab was given at a dose of 10 mg per kg IV Q2 weekly for up to 12 months. So this was compared with placebo of 10 mg per kg IV Q2 weekly for up to 12 months. So the primary endpoints were PFS and OS. So key secondary endpoints were overall response rate, duration of response, safety, and tolerability. So this is the updated 5-year overall survival in the intention to treat population. So look at the survival difference. Even at 5 years also, there is a significant difference. It's around 9% difference in the overall survival. So 9% might look like a small number, but trust me, it's not, because we are discussing about stage 3 lung cancer patients whom we always, sometimes when we counsel the patients also, we tend to say it might be stage 3, but sometimes it really behaves as stage 4. So we never know where there is a hidden metastatic niche. So in stage 3 lung cancer patients. So any difference is a good difference for stage 3 lung cancer. So at 12 months, there was a difference of 83 versus 74%. So at 2 years, it was 66 versus 55%. And at the end of 5 years, it was 42.9% compared to 33%. So first and only approved immunotherapy to demonstrate 42.9% overall survival at 5 years. So this is the updated progression-free survival with durvalumab. So 5-year PFS was 33.1% compared to 19%. So this has shown durable progression-free survival of 33.1% benefit at 5 years. So the summary of PACIFIC trial, it demonstrated a statistically significant improvement in PFS versus placebo with an hazard ratio of 0.52. So in all pre-specified subgroups, there was a PFS improvement. So it demonstrated a clinically meaningful benefit in overall response rate with durable responses, and median duration of response was not reached versus 13.8 months in the study. So they had, patients receiving durvalumab had a lower incidence of new lesions, including new brain metastasis. This is the only phase 3 study to demonstrate a statistically significant and clinically meaningful improvement in PFS and OS in this set of population. So in the placebo arm, it had a median OS of 28.7 months. So next comes the Caspian study. Caspian study I won't be discussing in detail because the previous speaker has already dealt about the study very precisely. So Caspian study basically established durvalumab plus chemotherapy as the standard of choice in extensive phase small cell lung cancer patients with a significant difference in PFS and significant difference in PFS. So we can see the numbers have almost quadrupled compared to the comparator arm. So 3 times more patients were alive in durvalumab plus chemotherapy arm versus chemotherapy arm at 3 years. So durvalumab is the first and only immuno-oncology agent to show a sustained long-term survival benefit up to 3 years in extensive stage small cell lung cancer patients. That ends my presentation.
Thank you so much, ma'am, for informative session. Next, I would like to welcome Dr. Aparjita Sadhya, medical oncologist, Narayana Health, Kolkata, to present a talk on IM-Forte trial, lurbinectedin plus atezolizumab in SCLC-ES. Over to you, ma'am.
Good evening, everyone. Am I audible?
Yes. Go ahead.
Okay, so I will focus on the study IM4. So this is a phase 3 trial of lurbinectedin plus atezolizumab versus atezolizumab as first-line maintenance therapy in extensive stage small cell lung carcinoma. So to begin with, the background of this study is although the first-line combination immunotherapy with platinum-based chemotherapy is associated with improved anti-tumor activity, the disease control rate in extensive stage small cell lung cancer is often temporary, unfortunately, in almost 60% of the cases, and we see early relapse or recurrence. So, lurbinectedin is an alkylating agent that works by binding to the minor grooves of the DNA, and it disrupts the activity of DNA binding proteins, and it interferes with the DNA repair pathways, leading to DNA breaks and ultimately cell death. So it has been approved for treatment of acute metastasis and PD on or after platinum-based chemotherapy. So, however, there is also a added benefit which has been shown in preclinical studies, which suggests that lurbinectedin may activate pathways that sensitize and tumors to PD-L1 blockade, and thus potentiating the efficacy of checkpoint inhibitors. So, lurbinectedin combined with immune checkpoint inhibitors was well tolerated and showed promising efficacy in both phase 1 and 2 clinical trials for relapsed extensive stage SCLC. So, this phase 3 study in atezolizumab versus atezolizumab as first-line maintenance therapy in patients with extensive stage SCLC without progressive disease following first-line induction therapy consisting of atezolizumab plus etoposide and carboplatin. So, the current treatment landscape for SCLC has been already discussed. So, coming to the study. So, the first screening for the study was carried out in 660 patients, and the eligibility criteria was no prior systemic treatment for extensive stage SCLC, no CNS metastasis, and ECOG-PS 0 or 1. So, all these patients enrolled in phase, and patient received atezolizumab along with carboplatin and etoposide for 4 cycles every 3 weekly. So, after 4 cycles, there was a second screening, and the eligibility criteria for the second screening was ongoing complete or partial response or stable disease following induction therapy and ECOG-PS 0 or 1, and total 483 patients were screened and randomized in a 1:1 fashion into either the lurbinectedin arm or the atezo arm. The lurbinectedin arm was to receive lurbinectedin along with atezolizumab, and the dose was 3.2 mg per meter square for lurbinectedin and atezolizumab 1200 mg cycled every 3 weeks until progression. And those patients who received only atezolizumab, the dose was 1200 mg every 3 weeks and continued until PD or unacceptable toxicity. And no crossover was allowed. So the efficacy endpoint assessment, it started from randomization into the maintenance phase, and safety analysis also was started from maintenance cycle 1, day 1. And these stratification factors were ECOG-PS 0 or 1, LDH, presence of liver mets at induction baseline, and prior receipt of PCI. And the primary endpoint of the study was IRF assessed PFS and OS, and the secondary endpoint was investigators PFS, objective response rate, and duration of response and safety. So the baseline characteristics, it was almost equal distribution was in both the arms, and here we can see that almost liver metastasis was equal, number of patients were equal in both the arms. 41% patients in lurbinectedin plus atezolizumab arm versus 39% patients in the atezolizumab alone arm, and the response to induction therapy, almost 88% patients had complete response or partial response in both the arms, while around 10 to 11% patients had stable disease in both the arms. So moving on to the results, the IRF PFS from randomization into the maintenance phase, at 6 months, the IRF PFS was 41.2% versus 18%, and there is a clear benefit, and as we can see by the separation of the curves, and the benefit continued even at 12 months, and there was 20% in the lurbinectedin plus atezolizumab arm, and versus 12% in the atezolizumab alone arm. And the median PFS was 5.4 months in the lurbinectedin plus atezolizumab arm versus 2.1 months in the atezolizumab alone arm, and with a significant p-value with a hazard of 0.54. Next, if we look at the IRF PFS subgroup analysis, almost all the subgroups had favorable response with the lurbinectedin plus atezolizumab arm. Next endpoint was the OS from randomization into maintenance. Here also, if we look at the OS, the 12-month OS was higher in the lurbinectedin arm, that is 56.3% versus 44% in the atezolizumab alone arm, and the median OS was 13.2 months in the lurbinectedin plus atezolizumab arm versus 10.6 months in the atezolizumab alone arm, with a hazard of 0.73. So there was the median OS from randomization was 13.2. That is, it was longer in the lurbinectedin plus atezolizumab arm, and versus 10.6 months in the atezolizumab arm. And again, if we look at the subgroup analysis, almost all the subgroups had a favorable benefit overall survival with the lurbinectedin and atezolizumab treatment. So now looking at the IRS assessed ORR and DOR during the maintenance phase. So at the time of randomization, 88% of patients had complete response or partial response, and 11% had stable disease to induction, and tumor response in maintenance phase was assessed against the baseline. So here we can see that the confirmed objective response rate was 19% in the lurbinectedin plus atezolizumab arm, as compared to 10% in the atezolizumab alone arm, and complete response was around 2.3% versus 0.5%, and almost 30 patients had partial response, and in the lurbinectedin plus atezolizumab arm, and stable disease was also higher in the lurbinectedin plus atezolizumab arm. While if we look at the progressive disease, it was higher in the atezolizumab arm, and the median duration of response was also higher in the lurbinectedin plus atezolizumab arm, that is 9 months versus 5.6 months. So, in the follow-up systemic anti-cancer treatments, number of patients who discontinued maintenance treatment was higher in the atezolizumab alone arm, that was 208, and patients with prior with more than one follow-up systemic anti-cancer therapy was also higher in the atezolizumab arm. So coming to the safety summary during the maintenance phase, that the toxicity profile overall, the all cause of adverse event was higher in the lurbinectedin plus atezolizumab arm, and mostly grade 3, grade 4 toxicities was around 38% in the lurbinectedin plus atezolizumab arm versus 22% in the atezolizumab or alone arm. However, if we look at the adverse events leading to discontinuation of the study, that was 6.2 in the lurbinectedin arm versus 8% in the 3.3% in the atezolizumab alone arm. So here we can see that mostly the toxicities were grade 1 and grade 2, and the grade 3, 4 toxicities was it was higher in the lurbinectedin arm, it was manageable. So coming to the conclusion, the IM40 study, it demonstrated a statistically significant and clinically meaningful improvement in the PFS and OS with first-line maintenance treatment with lurbinectedin plus atezolizumab versus atezolizumab in patients with extensive stage small cell lung carcinoma, and the stratified IRF PSF hazard was 0.54 with a p-value significant, and the stratified OS hazard was 0.73. The IRF PS and OS benefit with lurbinectedin plus atezolizumab was generally consistent across majority of the subgroups, and despite the higher rate of grade 3, grade 4 adverse event or serious adverse events, there were no new or unexpected safety signals with lurbinectedin plus atezolizumab. The safety profile was predictable with mostly low-grade adverse event and lower treatment discontinuation rate, and there was no clinically meaningful increase in immune-related adverse event. Thus, IM4 is the first phase 3 study to show PFS and OS improvement with first-line maintenance standard for extensive stage SCLC, highlighting the potential of lurbinectedin plus atezolizumab to become the new standard of care for first-line maintenance therapy in patients with aggressive and difficult to treat disease. So with this, I would end my talk. Thank you.
Right. Dr. Aparajita, well presented. I think what information we can get from this is the first maintenance in small cell lung cancer that has improved overall survival. But this is a chemotherapy. This lurbinectedin is like trabectedin, so it is in the same class. Difficult to deliver with toxicities. So let's see. It is only with Atezo. So what about other IOs? Can we come in other IOs? Is the thing that we will discuss. Thank you, Dr. Aparajita. Okay, Dr. Rupam. You can take up the next one. I think quickly you can finish in 5 minutes, Dr. Rupam. Just highlight the main points and quickly finish in 5 minutes.
Good evening, everyone. Am I audible?
Yes, he's audible. Go ahead.
So my topic is today tarlatamab in small cell lung cancer. We previous speakers already discussed about the these things: staging, extensive and limited stage. This is the present standard of care. Now this is the list of second line and emerging treatment for small cell lung cancer from NCCN guidelines. So we can see here from the CT for chemotherapy free interval more than 6 months, and also for less than equal to 6 months. In both cases we can use tarlatamab. So other second line treatment options, that is topotecan, lurbinectedin, rechallenge with platinum-based chemotherapy if progression-free interval is more than 6 months, and then followed by tarlatamab. So this is the emerging option. So what is tarlatamab? This is a BiTE therapy in small cell lung cancer. It is a bispecific T cell engager. So from this picture, you can see it simultaneously bind to DLL3 receptor, a protein expressed in 85% of small cell lung cancer cases, and also CD3 presented on the T cells. This dual binding redirects the patient's own T cells towards the DLL3 positive cancer cells, causing this targeted immune mediated killing. So this early phase trial shows promising efficacy, and then however, cytokine release syndrome and neurotoxicity are important side effects of this molecule. And then if we delve into the trials of related to the tarlatamab, so the first trial, which is phase 1, Delphi 300 trial, this is a phase 1 study which is first shows the encouraging early efficacy, that is objective response rate 23%, overall survival 13 months, durable response 13 months, and then manageable safety profile. And this trial laid the groundwork for phase 2 Delphi 301 study, which showed stronger efficacy and led to FDA accelerated approval. So about Delphi 301 trial. This is an open label multi-center trial assessing tarlatamab in relapsed or refractory extensive stage small cell lung cancer. So efficacy wise, overall objective response rate was 40%, median duration of response was 9.7 months, median overall survival was 14.3 months. Safety profile: common adverse events include cytokine release syndrome, and serious toxicities include ICANS, that is immune effector cell associated neurotoxicity syndrome. Then FDA approval of tarlatamab was 16 May 2024 based on this phase 2 study. Dosing initially 1 milligram IV infusion followed by 10 milligram every 2 weeks. And if we see the study design, here we can see that in 3 parts. Part 1, dose evaluation was done, followed by in part 2, dose expansion, and part 3, reduced inpatient monitoring period. So and the baseline characteristics of the study was shown here in this chart. So you can see that then if we see the response waterfall curve of the further response of this Delphi 301 trial, we can see that for tarlatamab 10 milligram and 100 milligram, objective response rate was 40 and for 100 milligram it is 32. And from this waterfall curve, the key findings which we can find, that is both doses showed tumor shrinkage in many patients. The majority of patients had more than equal to 30% tumor reduction, that is partial response or better. Responses occurred across DLL3 expression levels. Even in patients with undetectable or unevaluable DLL3, responses were still seen. And dose comparison, both 10 milligram and 100 milligram dose showed substantial activity. So earlier data showed 10 milligram selected as preferred dose. And the key findings from this curve, from this chart, we can see that is the rapid onset of response, that is median time to response is 1.4 months, durable response, that is long lasting response for more than 40 to 60 weeks, ongoing benefit at cutoff 55% of responders were still in response. And so in relapsed or refractory small cell lung cancer, durability of this molecule is highly significant. And this is the survival curve. It achieved a median overall survival of 14 months in heavily pretreated extensive stage small cell lung cancer, and this is why it gained this FDA accelerated approval. Then this is the curve for safety profile. CRS is the most common toxicity, mainly in early cycles, manageable with step-up dosing, monitoring, and supportive care. And neurotoxicity is rare but requires vigilance. By cycle 2 onwards, safety profile is much more favorable. So this is the conclusion of this trial. That is objective response rate was 14.40%. Then the most common treatment-related adverse event CRS, and tarlatamab 10 milligram was the selected dose for further development. This sets the background for Delphi 304 study, which will compare the efficacy and safety of tarlatamab with standard of care chemotherapy. So this data was published in June 2025. So this is the Delphi 304 study, and the study design, it is a phase 3 study, population extensive stage small cell lung cancer post platinum chemotherapy. Groups of patients were selected, and primary endpoint was overall survival, secondary endpoint PFS, ORR, and depth of response and safety. So final results, it is announced in mid 2024 in June. So statistically significant and clinically meaningful improvement in overall survival with tarlatamab, and better PFS, higher objective response rate, longer duration of response. The key finding just I will discuss here, that is median overall survival was 13.6 months with tarlatamab versus 8.3 months with chemotherapy. Statistically significant hazard was 0.6, and median PFS was 4.2 months for tarlatamab versus 3.7 months, and hazard was 0.71, that is statistically significant. Objective response rate for tarlatamab 35% versus chemotherapy for that is 20% with more durable response. And patient reported outcomes, significant improvement in dyspnea and cough symptoms with tarlatamab. And safety profile, we can see the lower rate of grade more than equal to 3 treatment related adverse event, 27% versus 62%, and fewer discontinuation. And these cytokine release syndrome events were mostly low grade and occurred early, they were manageable. So this is the treatment response which I already discussed. Then this is the overall survival curve, 13.6 months for tarlatamab. This is static curve was separated, and so it is statistically significant. This is the PFS curve which I already mentioned. So clinical impact, this is the first DLL3 directed therapy to show overall survival benefit in relapsed small cell lung cancer, and it represents a new treatment option beyond topotecan lurbinectedin. And this FDA approval it got on the basis of this study. So final message I can give, that on the basis of the from the evolution from phase 1 Delphi 300 to phase 2 Delphi 301 study, finally FDA accelerated approval, and finally the result of this phase 3 study which has confirmed OS benefit over standard chemotherapy, establishing this BiTEs, that is bispecific T cell engager, as a new standard in second line small cell lung cancer. And it represents a major advancement in this deadly disease, offering patients meaningful survival benefit where options were previously limited till now. Thank you.
Well presented, Dr. Rupam. I think tarlatamab is a revolutionary molecule. It's a BiTE improving overall survival in subsequent lines, which was unheard of in small cell lung cancer. The responses, the survival curves are really effective. So based on this, CAR Ts are also coming up for the for small cell lung cancer space. I think in another couple of years, you will have CAR Ts coming in this space. Thank you, Dr. Rupam. Okay, now let me request Dr. Preetham. So Dr. Preetham, request you to quickly take us through the serplulimab data. Yeah, share and start. Rupam, stop sharing the slides and let Dr. Preetham share.
Yes.
Complete in 10 minutes, Dr. Preetham. You're not audible, Preetham. Preetham, you're not audible.
Okay, sir.
Yeah, you're audible. Start.
Just a minute, sir. So, good evening, everyone. Today, my topic of discussion is serplulimab in small cell lung cancer. So, in next few minutes, we'll be discussing the trends of SCLC in Indian scenario. Number 2, current standard of care. Number 3, role of IOs, and the recent updates. So, first, So what is the current scenario, Indian scenario of SCLC in India? So as per Globocon 2022, lung cancer is the fourth most common cancer in India. Incidence is 81,743 and 15% of newly diagnosed lung cancer are SCLC. So SCLC in India, large data with long-term follow-up on SCLC from North India, 361 patients with SCLC, 73.3% of SCLC are extensive stage SCLC. So SCLC in India trends, SCLC cases dropping to half from 16% in 2008 to 8% to 2020. So what is the current standard for management of extensive stage SCLC prior to IO era? So platinum-based first-line chemotherapy, either cisplatin or carboplatin. Cisplatin is 60 to 75 milligram per meter square, or carboplatin AUC5 on day 1 and etoposide 80 to 120 milligram meter square day 1 to day 3, 4 to 6 cycles, 3 weekly interval. Then consolidation with thoracic irradiation with 40 to 50 gray in selected patients. Prophylactic cranial irradiation or PCI of 25 gray for patients in CR or PR and good general condition after CT outcomes with first-line treatment. Relative risk is 50 to 60% and median overall survival is 9 to 10 months of those who got PCI. Second-line chemotherapy in cases of recurrence or progressive disease after first-line, either rechallenge or topotecan paclitaxel. Outcome with second-line treatment is relative risk 10 to 20% and median overall survival is 5 to 6 months. Lack of significant drug therapy progresses over the last 40 years. So the chemotherapy was extensive stage SCLC. So in a meta-analysis of published data of 19 trials, which included 4,054 patients, odd ratio for response rate is 1.35 in favor of cisplatin with a p-value is 0.0001. And odd ratio for 1 year survival is 0.80 in favor of cisplatin with a p-value of less than 0.0002, corresponding to an absolute survival improvement of 4.4%. So odd ratios and 95% confidence interval of mortality at 1 year for patients treated with a CDTP continuous regimens. These are the diagram. So chemotherapy for extensive stage SCLC, the role of platinum, whether we'll use carboplatin or cisplatin. So if you see the overall survival and progression-free survival, both are equal. So in case of cisplatin, the median OS is 9.64 months and for carboplatin is 9.41 months. And for progression-free survival, for cisplatin is 5.46 months and for carboplatin is 5.33 months. So now the role of thoracic radiation. That TRACE trial addresses this issue. This trial shows that thoracic external radiation therapy with PCI prolongs overall survival in patients with extensive stage SCLC who responded to chemotherapy with residual intrathoracic disease, with a hazard ratio is 0.80. Now the role of PCI. A multi-center URTC clinical trial randomized 286 patients with extensive stage SCLC achieving any responses to chemotherapy between PCI or no PCI. Brain imaging at randomization not mandatory. Median overall survival increases by 1.3 months, 5.4 months versus 6.7 months with PCI, and OS at 1 year increased from 13.3% to 27.1%. and decreased symptomatic brain metastasis from 41.3% to 16.8%, which is a p-value is a 0.001. So these are the failed anti-cancer treatment strategy. That is high-dose chemotherapy that cannot work, accelerated chemotherapy, alternate or sequential chemo regimens, adding third, fourth chemo drug, more chemo cycles, that beyond the 4 to 6 cycles, maintenance therapy, biotherapies like the TKI, metalloproteinase inhibitor or farnesyl transferase inhibitor. So this is the development of standard therapy in extensive stage SCLC. These are the roadway. So now the IO agents for extensive stage SCLC. Initial IO agents like pembrolizumab, nivolumab were tried in SCLC. Both showed data on ORR However, on long-term follow-up of both lungs, no OS benefits were seen. Hence, SCLC indication for both Pembro and Nivo was later withdrawn from USA. So these are the data. So for nivolumab, two data is there. One is CheckMate 331 and CheckMate 451. So in CheckMate 331, they uses only Nivo, and CheckMate 451, they uses Nivo EP. This is 3-arm actually study. One is Nivo EP arm, one is Nivo arm, and one is chemotherapy arm. So you see, for Nivo CheckMate 331, the nivolumab had a median overall survival is 7.5 months with and chemotherapy is 8.4 months. So it is a negative study. For CheckMate 451 in Nivo EP arm, so median overall survival is for 9.2 months, and for placebo it is 9.6 months. And for nivolumab arm, this is 10 point for nivolumab this is 10.4 months, and for placebo it is 9.6 months. So this is the Keynote 604, which addresses the pembrolizumab immunotherapy. So you see the median OS is 10.88 months for pembrolizumab, and for EP it is 9.7 months. So this is two study already discussed. One is IMpower 133, which uses atezolizumab with carboplatin with etoposide. And second is Caspian study, which use durvalumab along with carboplatin or cisplatin plus etoposide. So this is the 5-year overall survival. 5-year overall survival for IMpower study is 12%, and 3-year overall survival is 17.6%. So this is a phase 3 trials with first-line platinum etoposide plus immunochemotherapy in extensive stage SCLC. So delta for OS is 2 months for atezolizumab, and for delta for OS for 2.7 months for durvalumab arm, and hazard ratio for IMpower study is 0.70, and for Caspian study it is 0.73. So the recent updates, we will discussing the role of serpulimab, which is a PD-1 receptor inhibitor with a differentiated mode of action. How is serpulimab is different from Nivo or pembrolizumab? So this has a co-signaling of CD20 mediated signaling, and that is a co-signaling. So PD-1 forms a cis complex with the CD28 co-stimulatory receptor. This colocalization would bring CD28 associated intracellular kinase essential for T cell co-stimulation into contact with PD-1 associated SHP2 phosphatase, resulting in a reduced co-stimulatory effect. Serpulimab blocks that co-clustering of CD28 with PD-1 during T cell activation better than pembrolizumab, which is evident in this immunoprecipitation performed with serpulimab showed significantly lower levels of PD-1 CD28 complex after T cell activation versus pembrolizumab. So this is the Astram 005 study. They included more than 18 years patients with a histologically proved extensive stage small cell lung cancer, no prior systemic therapy for SCLC, at least one measurable lesion, and ECOG performance status is 0 or 1. So they use serpulimab 4.5 milligram per kg on day 1 along with etoposide day 1 to day 3 with a 100 milligram per meter square dose, and carboplatin AUC5 on day 1 for 4 cycles, followed by serpulimab 4.5 milligram per kg on day 1 for 3 weekly until disease progression or intolerable toxicity. With a standard arm is etoposide and carboplatin. So this is the result. The first PD-1 inhibitor achieves positive results in international phase 3 clinical trials for extensive stage SCLC with a hazard ratio for OS is 0.63 and delta for OS is 4.5 months. There is a clear separation of survival curve. So this is the updated trial after a median follow-up 42.4 months with a hazard ratio for OS is 0.60, and 4-year overall survival is 21.9%, and proportion of patients alive at 4 years is 3 times versus chemo. That is important. And you see the separation of curve begins at the beginning, and the separation continued till the end. So this is the cross trial comparison, that is IMpower 133, Caspian and Astram. You will see in Astram 005 study, that is the sertolizumab trial, higher percentage of ASEAN patients, higher percentage of patients with PS1, and higher percentage of patients with brain mets. So this is the updated OS in subgroup analysis. So you will see every subgroup has benefited with sertolizumab with an impressive hazard ratio. So this is a cross-trial comparison as per efficacy. So you see the OS 15.8 months for sertolizumab, 12.3 months for atezolizumab, 12.9 months durvalumab, 15.5 months for tislelizumab, and toripalimab is 14.6 months. And duration of response is also more in sertolizumab, that is 6.8 months for sertolizumab, 4.2 months atezolizumab, 5.1 months is durvalumab, 4.3 for tislelizumab, and toripalimab for 5.3. And for PFS and ORR also better in sertolizumab. So MCBS score says that sertolizumab is a 4 score. For atezolizumab it is 3, durvalumab for it is 3, and for tislelizumab it is 2. This is as per ESMO recommendation. So highest ESMO magnitude of clinical benefit, that is MCBS score in ES-SCLC, independently assessment by ESMO expert assigned the highest MCBS across immunotherapies for extensive stage SCLC, indicating substantial clinical benefit, and already I have discussed this is 4. So currently sertolizumab, the current indication is extensive stage small cell lung cancer, squamous non-small cell lung cancer, non-squamous non-small cell lung cancer, esophageal squamous cell carcinoma, and microsatellite instability high, that is MSI high, solid tumor. So thank you, and I will end my topic.
Well presented, Dr. Preetham. So, Dr. Preetham, if you want to share some of your thoughts on what are the positives and shortcomings of the sertolizumab use in small cell lung cancer, any thoughts? What are the positive points you want to share with the audience?
Sir, there is an clear-cut OS benefit, ORR benefit, and PFS is also impressive, sir.
Right. So the hazard ratio for survival is far better than the other two existing IOs.
Yes, sir.
And you see the absolute number, absolute median overall survival is longest for sertolizumab
Longest for
when compared to the other immunomolecules. The toxicity is similar, and they've
toxicity
used
is 33.3%. Almost in Astram 005 trial, it showed that 33.3% has grade
Right.
3 or more toxicity.
Right. ठीक है. Chalo, okay. Thank you, Dr. Preetham. Okay, so now we can quickly go to the panel discussion on small cell lung cancer. Okay. So let me share the slides. Can I share the slides?
Yes, sir.
Right. So let me start from Dr. Nivedita, then Dr. Preetham, and then Aparajita, and then Dr. Rupam in the same order. Okay. So I think lurbinectedin plus atezolizumab, I think it's an alkylating agent. It has improved PFS OS. The problem is it's as toxic as chemotherapy. Right. So, Dr. Nivedita, you can take up this. So what do you name these things? You know, pericardial effusion, pleural effusion, contralateral supraclavicular. all these are covered under the definition of extensive stage. So, but do you tend to cover these also in CTRT field?
No, sir. As there is a malignant pericardial and pleural effusion, and there is a contralateral supraclav also, the definition includes that it should be the definition of limited stage includes that it should be covered by, it should be encompassed
Single radiation field, right?
and tolerable it should be. So we should
Right.
not extend extensive lung field also. So the toxicity will increase. So we will consider it as a extensive stage disease, and we will go ahead with systemic therapy first.
Right. So may I request Dr. Monideepa? So
Yes, am
hi,
I
Dr.
audible?
Monideepa.
Hi.
Yeah, Dr. Monideepa. So will you consider any of these under limited stage when you are treating?
No, I'm not going to consider this.
Okay.
Though the contralateral hilar, if the ipsilateral disease is also limited to that
Right.
portion, hilar region, then we can take it within the portal. Though the lung
Right.
pneumonitis or toxicity of V20 will be slightly more, but still it can be covered.
Right. What about contralateral supraclavicular?
No, if it depends, because contralateral supraclavicular with an ipsilateral apical tumor, still we will be able to.
Right.
But if
Right.
it is in the lower lobe, it is not possible, or middle
Right.
lobe also, it's not possible.
Understood. Again, it's a case to case, but roughly these are usually extensive stage. In selective patients, we can look into supraclavicular and contralateral hilar. Thank you.
Yes.
Thank you. Right. So this is cisplatin and carboplatin. So Dr. Preetham, what do you use? You have meta-analysis of cis equals carbo in terms of both. So do you use both cis and carbo interchangeably in small cell lung cancer extensive stage?
Yes, sir. As per overall survival and PFS data, the
Right.
efficacy of carboplatin and cisplatin are same. Okay.
Correct. So this is a meta-analysis of multiple trials, and that says cis equals carbo. And this is cis carbo, OS, PFS. This is similar. Okay. And now the backbone of chemotherapy. So, Dr. Aparajita, so what do you use usually in as a chemotherapy backbone with extensive stage small cell? Do you use cis or carbo in your practice? You have Aparajita? Right. I think we use both. Yeah.
Yes, with atezolizumab, we mostly use
So
carbo.
this is a clinical trial. This is a clinical trial data. But I think in practice we use both of them. Right.
We use both.
Right. It depends on the toxicity. If someone has cytopenias, marrow is an issue, then we will use cis. If someone has nephro issue, then we will use carbo. So again, either of them can be used. But the clinical trial uses carbo itopo with atezo and cis or carbo with durva. Right.
Sir, I have an opinion.
Right.
Is performance status of a patient you will use carbo or cisplatin is depends on the patient's performance status?
Well, not exactly. Like performance status 3, you will go for like abbreviated chemo. You'll go for weekly carbo or something like that, or a 1 day of A2 carbo. So is one of the factors. So overall, performance status is not an individual factor. Along with that, creatinine clearance, all these things come into account, right?
Okay.
But it's equivalent. It's equivalent. You can use either of them. That's what it means.
Okay.
Right. So what about this one? I gave induction chemo. Let's say I gave 6 cycle ito carbo itosis, and then there is a good response, and now I can put them on immunotherapy maintenance. So there is a trial of Checkmate 451 where they used after chemo they used nivo EP. It's negative. Again, not giving immunotherapy along with chemo, and then only giving chemo followed by immunomaintenance is a negative trial. This is nivo EP. Whereas if it is limited stage, there you have to give chemo RT and then immunotherapy maintenance. So if it is extensive stage, there your immuno will start from cycle 1 chemo itself. Whereas for limited stage, you have to give chemo first and then immunotherapy maintenance. So that distinction is very important. So, well, Dr. Monideepa, can I request you one thing?
Yes.
Is there an instance where it's difficult to decide whether it's CTRT or I will give consolidation RT later? Like you give 1 or 2 cycles and then let us do a CTRT later. Is there any instance that you come across in practice? Like initially, I'm not
Extensive
sure.
stage.
Initially, I'm not sure whether it is extensive or limited.
Yeah.
You give some 3-4 cycles. If there is good shrinkage, then let me give CTRT.
Yes.
Does that
Yes, there
happen?
are. It's very limited number of metastasis, not widespread metastasis to different other regions. Like you said, contralateral supracleft maybe in
Right.
certain cases. I have given 1 or 2. We have discussed in tumor board. There was cervical node, and
Right.
then it came down, and it was apical lobe tumor. So we decided to go ahead. So this
Right.
was another case.
So there is an issue with immunotherapy, because if I start with chemo immuno as an extensive stage, then I cannot continue immuno along with radiation because the toxicity is higher. So there is an issue if I use chemo immuno. So the suggestion is, if we are treating with CTRT at any point of time, we should not be giving IO in the induction chemo. We should be giving only chemo and then use IO maintenance as per Adriatic plan. So that is some soft difference. So what about Pembro data? Pembro is also there, but the hazard ratio is not impressive. It was not significant. Nivo, there is a phase 2 data of giving Nivo along with chemo, but they didn't do a phase 3 trial. But the hazard ratio is impressive when with nivolumab. So irinotecan cisplatin. So irinotecan also in Japanese patients, they have shown OS is better, but it was not replicated in the global scenario. So irinotecan cisplatin, in case you cannot give etoposide, irinotecan is a reasonable alternative. And this is trilaciclib. This is an IV CDK4 inhibitor that reduces myelosuppression, but it doesn't reduce FN. So this is also been coming in future in small cell lung cancer space, and this is thoracic RT. So, right. So thoracic RT, there was a randomized trial that said there was no benefit, and then they looked into the subset where there was residual disease in the chest with no extrathoracic disease. It improved OS. So again, let me request, do we have Atul? Yeah, we have Dr. Atul.
Yes,
Hi,
yes.
Dr. Atul. Good evening.
Hi.
Hi, Dr. Atul. So your comments, Dr. Atul. So thoracic RT data is basically for this subset where there is residual disease in chest, no extrathoracic disease, has improved OS. This is in the pre-immunotherapy era. What about immunotherapy era? What do you think we should be giving thoracic RT?
Yes, we should be giving thoracic RT.
Right. What is your experience? How do you look into it?
In limited stage, we first go with the as usual chemotherapy for 1 or 2 cycles, followed by CTRT. But
Right.
in extensive stage, if it's a limited, in extensive stage also, there is a less meds who are all responded to chemotherapy, then we can go ahead with the thoracic RT as a consolidation RT.
Right. So as you correctly pointed out, so consolidation RT, that is radiation to the residual disease, like I gave chemoimmunotherapy for 4 to 6 cycles and I did a scan. There is excellent response everywhere and there is only residual disease in the chest. So there, if I give radiation, so definitely it improves overall survival, and all these trials are in the pre-immunotherapy era. In the immunotherapy era, the trials excluded, they didn't give thoracic RT because the moment I give thoracic RT, then it is difficult for me to assess by RECIST. Like I do not know whether it is not progressing or not. So they excluded just because they cannot assess the efficacy of immunotherapy later on. Not that they wanted to avoid thoracic RT. Probably we can extrapolate the data even in the
Yeah,
immunotherapy.
quick comment if I can do.
Right, right.
Yeah. So actually, there are some recent meta-analysis, though there was significant heterogeneity. So Wang Feng et al. Meta-analysis in 2024, recent, they have shown that with chemo IO, the thoracic RT can be given, and in that case also 6-month and 1-year OS PFS improvement is there. There are certain retrospective like Korean studies are there, but still randomized trial is not there, and triplets or raptor studies, they are looking into it. These are ongoing randomized study. But based on this, the recent Canadian consensus and the ASCO, the recent guideline, they have suggested that you can go ahead with consolidated thoracic RT if there is a significant response and there is no extra thoracic meds or low number of extra thoracic meds, and also if the PS of the patient is good.
Great. Agreed. I think yes. So even in the immunotherapy era, as you said, we can give thoracic CAR-T. There are trials required. I think there are a lot of Indian trials going on, a lot of TMH trials going on. Small cell lung cancer is a difficult disease to have randomized trials. So we have Dr. Sucheta, who has joined from TMH. She is actively involved in all clinical trials in TMH. Dr. Sucheta, you want to just share some of the clinical trials in non-small cell lung cancer space that you're actively pursuing right now in TMH on one or two trials? We have Dr. Sucheta join. I think.
Hi, Dr. Chandrakant. Yes, we are doing 18 studies, which in
Right.
which active recruitment is going on, and in five studies, patient is on follow-up. So 15 studies we are doing in palliative setting, and 3 studies in curative intent.
Right.
So yeah.
We see a lot of LiquiAct study patients coming, like, deciding
Yes.
treatment based on the liquid biopsy reports. I think a lot of attractive trials happening, and
Yes.
great to treat clinical trial patients even in our OPD. Thank you. Okay. Right. Thank you, Dr.
Thank
Sujata, for sharing.
Yeah. Thank you.
So this is again, this is what the CREST trial that showed that thoracic RT can be given, that improves OS, and even in the immunotherapy era, this can be replicated. Coming on to PCI. Dr. Atul, your take on PCI in extensive stage, PCI or no PCI. So PCI reduces brain mets and also improves overall survival. Your take, Dr. Atul.
In my opinion, in extensive stage, if it's a good response to chemotherapy after 4 to 6 cycles or with IO, so I will still consider to give PCI.
Right. So you can see the results, like it has improved overall survival, and also the brain metastasis has reduced significantly. Right. Thank you. So, but if you look into the immunotherapy trials, like the couple of trials what we discussed before, the Caspian and the atezolizumab trial, so PCI was optional, and 50% of patients they avoided PCI because of the long-term neurological toxicities. So, Dr. Monideepa, your thoughts, PCI versus MRI surveillance. If I do an MRI surveillance and avoid PCI, the survival is equivalent. So, any space for MRI surveillance in any subset of patients where you would avoid PCI in the immunotherapy era, especially because they're going to live long, they're not going to die like it used to happen in the pre-immunotherapy era. Your thoughts on avoiding PCI and MRI
MR
surveillance?
surveillance, according to the Japanese study Takashi et al., it is actually equivalent to that of the survival is equivalent to that of the our PCI. But a problem with surveillance is that every 3 monthly doing it for 1 year and then 6 monthly in the next 1 year. So it's going to cause a lot of financial burden to the patient. So that is one thing. And the second thing is that in case of we have some data coming up from the Adriatic trial in the limited stage that it can be like they have given a subset where PCI versus no PCI. PCI is associated with improved survival. That is from the limited stage where they have used along with our IO chemo IO. So it can be pulled in, but yeah, if the patient can do MRI, we should go for
Right.
MR survey.
Right. Hardly you get, hardly you get less than
Hardly we
less than
get
5% patients
less than 5%. Yeah.
who agree with this. What about SVCO? If there is SVCO, Dr. Atul, do you do CTRT if there is a supravenicular obstruction? Do these patients qualify for chemoradiation at any point of time? Dr. Atul, Dr. Monidip, yeah, Dr. Atul.
Yeah. So after good response to the chemotherapy, they
Right. You will do
qualify for
consolidation.
the CTRT, right?
Right. Thank you, both Dr. Monidipa and Dr. Atul. You shared your thoughts very effectively. Right. So this is the comparison of three immunotherapy molecules. Very important is the cost effectiveness. It's like almost 40-50% of the cost of the existing IOs. What you can see, and serplulimab has got the longest median overall survival. You can see the hazard ratio is 0.61 and 15.8 months. This is the first trial to show the longest median overall survival ever in small cell lung cancer, extensive stage. Hazard ratio is 0.61. The OS difference is 4.7. The number of patients living at 3 years is 25%. So, Dr. Rupam, your thoughts on these impressive overall survival cross-trial comparisons? Do you still believe that these Chinese molecules, especially serplulimab, is there a barrier for you to use these, or how do you look at these molecules?
No, sir. From this recent data, I think, and considering the OS benefit and this 2-year and 3-year OS benefit, we should use serplulimab in our daily practice if it is available at all.
Right, it is there. It is available commercially. It just costs 25,000 for one. It is one of the most economical IO what we have. So, Dr. Nivedita, what is your thought? So, is this a practice-changing trial? I think Pritham presented the Astrum 005.
Yes, sir. So, yes, as we had a barrier for, especially in our practice, we see a lot of patients who have financial constraints, so who are unable to explore the benefit of immunotherapy. So as it is a cost effective in a way, and with a good outcome, and with a very good data of having a good OS and the PFS benefit, so I think it is a good choice to we can a more number of patients can explore the all the benefit of immunotherapy, and I think it is a good choice for us.
Right. So, if you actually look at the scientific data, excellent. There is no barrier for using these molecules in our practice, and this is tarlatamab, what Dr. Rupam presented. Again, fantastic. Once it comes, it will be very effective for us. This is yeah. So this is just a comparison, and this is serplulimab. Is little different than others because of the co-localization of CD28, which doesn't happen with other immunotherapy molecules. Dr. Pritham, what do you say, or what do you look into? How do you look into this distinct mechanism of action of serplulimab when compared to Pembro or other molecules?
Already I told that,
Right. Go ahead.
Sir, basically for serplulimab, the key point is that PD-1 forms a cis complex with the CD20 co-stimulatory receptors that could not available for pembrolizumab and other IOs. So this
Right.
is the key for this.
Yeah, in China they call it as next generation IOs. Okay, so they call Pembro Neo as early generation and serplulimab as a next generation IO, and that is reflected in the clinical trials and in the preclinical data also, especially on the PD-1 internalization is higher with serplulimab, resulting in a more durable response. So this is the difference of 4.5 months, delta of overall survival and hazard ratio is the best. And the long-term survivors, like 1/4 of patients crossing 3 years, again was never heard of in small cell lung cancer. And this is the comparison of the three. The cost is almost 30-40% of the cost of these expensive IOs, but having a much more impressive data, higher Asian patients, greater number of PS1, brain mets, and you can see the hazard ratios, they're very impressive. So therefore, the magnitude of clinical benefit scale score is highest for serplulimab. It's 3 for Atizo or Durva, and it is 4. So the magnitude of clinical benefit is best, and for Tisla it is 2. So in small cell, if you have the next day morning, you are justified in using serplulimab based on the available data, and it is approved by the DCGI, and it's an on-label practice in India. So I think we had a very fruitful discussion with serplulimab being available to us, more economical. We should be able to expose a greater number of patients of extensive small cell lung cancer in our practice. So I would thank all the panelists, especially Dr. Monideepa, Dr. Atul, and Dr. Sucheta from Mumbai for joining and sharing your valuable thoughts. Thanks all of you.
Thank you.
Thank you.
Thank you. Good night all.
Thank you, everyone.